Stop scrolling. Seriously, listen to this. If you see a child with deep, rapid breathing and a fruity odor, is it a lung infection? Well, if you said yes, you literally just failed the NCLEX. This is metabolic acidosis. Today, we are going deep into the endocrine system with this masterclass explainer so you never miss a detail like that again.
Part A, fever and dehydration management. Okay, let's dive right into this high-stakes masterclass by looking at interventions where students easily lose points. We are starting with something that seems simple, but man, it is packed with clinical traps. First step, we need to establish our baseline. In pediatrics, a normal temperature can bounce around a bit, but the strict numerical cutoff you absolutely need to burn into your brain for a fever is 38.0 degrees Celsius or 100.4 degrees Fahrenheit. Anything at or above this exact number requires our immediate clinical assessment. You are looking out for flushed skin, diaphoresis, and those really subtle changes in behavior, like sudden restlessness or lethargy. So the crucial point here is how we intervene. A super safe, highly tested intervention is a tepid water sponge bath for about 20 to 30 minutes. But here is the fatal trap: aspirin. Acetylsalicylic acid is strictly forbidden in children unless it is specifically prescribed for rare conditions. Why? Because it carries a severe risk of Rey syndrome, which causes acute encephalopathy and profound liver damage. Do not fall for the aspirin trap on your exams. Now, notice how we evaluate the fallout of fever and illness, which is dehydration. Because children hold way more of their body water in the extracellular fluid compartment compared to adults, they are incredibly vulnerable to fluid volume deficit. Look at how a child transitions from mild dehydration, where they might just be a little cranky and thirsty, to severe dehydration, where they become completely lethargic, have parched mucous membranes, and show very delayed capillary refill. Recognizing these subtle, progressive shifts is exactly how you save an infant from hypotonic shock. Part B, phenylketonuria. The deep dive. Let's move to our next section and see how a single genetic defect completely alters a child's metabolic pathway. PKU is an autosomal recessive disorder where the body completely lacks the enzyme phenylalanine hydroxylase. This basically means the child cannot break down phenylalanine, which is an essential amino acid. Normal blood levels are between 0 and 2 milligrams per deciliter. But in a child with PKU, toxic levels can skyrocket to greater than 20 milligrams per deciliter. If not immediately managed, this severe toxicity directly attacks the central nervous system, leading to seizures and irreversible mental retardation. Now, what is absolutely critical to notice here is the lifetime dietary protocol required to keep this child safe. You must completely restrict high-protein foods. That means meat and dairy are strictly forbidden. You also have to watch out for hidden dangers like aspartame, which is often found in diet sodas because it contains massive amounts of phenylalanine. Instead, these infants and children rely on special preparation formulas to get the nutrients they need for growth, totally avoiding the neurotoxicity. Because the stakes are incredibly high, all 50 states mandate routine newborn screening, often called the Guthrie test. But listen, timing is literally everything here. The infant must have begun formula or breast milk feeding before the specimen is collected. Think about it, otherwise there is no phenylalanine in their system to measure. And if the initial screen was done before 48 hours of age, you absolutely must rescreen them by 14 days to ensure you didn't get a false negative. Part C, diabetes mellitus type 1. The full protocol. Let's shift gears to another major endocrine disorder. We are focusing on absolute insulin deficiency due to the destruction of pancreatic beta cells and the critical protocols you really need to master.
You must instantly recognize the classic 3 Ps: polyuria, polydipsia, and polyphagia. That's excessive urination, excessive thirst, and excessive hunger. But please do not miss the secondary signs, like unexplained weight loss, lethargy, and a fruity breath odor. That fruity odor is a massive red flag that tricks so many people on exams because it's often mistaken for respiratory distress rather than a severe metabolic crisis.
This exact sequence illustrates precisely why that fruity breath happens. Look at this devastating cascade. Without insulin, glucose cannot enter the cells. The cells literally begin to starve while swimming in a sea of sugar. In response, the body desperately breaks down fats for energy, which produces ketones as a byproduct. These ketones build up in the blood, dropping the pH and leading to diabetic ketoacidosis, or DK. To compensate for this severe metabolic acidosis, the body triggers deep, rapid breathing to blow off excess carbon dioxide. Those are your classic Kussmaul respirations. But what happens when blood sugar drops way too low? Hypoglycemia is defined as a blood glucose level less than 70 milligrams per deciliter. The child might become shaky, irritable, and diaphoretic. Your absolute priority nursing action is the 15-15 rule. First, verify the level. Second, give 10 to 15 grams of simple, rapid-releasing carbohydrates, like half a cup of orange juice. Third, wait exactly 15 minutes and retest. If they're still dangerously low, you just repeat the whole process. When teaching parents about insulin administration, precision is non-negotiable. For infants, insulin may actually need to be diluted to avoid profound hypoglycemia. You also must teach them to rotate administration sites. This prevents lipodystrophy, which are those hard lumps that severely interfere with insulin absorption. Also, remember the golden rule. Always draw up clear, rapid-acting insulin before cloudy, longer-acting insulin. And perhaps most importantly, the sick day rules. Never, ever withhold insulin during illness, infection, or stress, even if the child is vomiting. The body's natural stress response spikes blood sugar, and withholding insulin is a very fast track to DKA. The NCLEX visual quiz, the crucible. All right, shift your focus. It is time to test your knowledge. I am going to read out 5 actual exam-style questions, giving you 7 seconds on the clock for each. Let's see if you can actively recall what we just covered. Get ready? Question 1. A child is diagnosed with PKU. Which milk substitute should the nurse expect to be prescribed? Is it A, whole cow's milk, B, soy-based formula, C, low-phenolac formula, or D, condensed milk? I will give you 7 seconds.
All right, time is up. The answer is C, low-phenolic formula. Remember our talk on diet? Low-phenolic is a special preparation formula that is low in phenylalanine, but provides enough nutrients for growth. Cow's milk and condensed milk are just way too high in protein.
Question 2. Which assessment finding is a classic sign of diabetic ketoacidosis? A, bradypnea and diaphoresis. B, deep, rapid respirations and fruity breath. C, shallow breathing and bradycardia. Or D, excessive salivation and tremors. 7 seconds, starting now. Okay, the correct choice is B, deep, rapid respirations and fruity breath. These are Kussmaul's respirations. It is the body's physiological attempt to blow off CO2 to fix the dangerous metabolic acidosis caused by that ketone buildup. Question 3. A 10-year-old with type 1 diabetes becomes shaky and irritable during gym class. What is the first action? A, administer 5 units of regular insulin. B, provide 4 ounces of orange juice. C, check the urine for glucose. Or D, call the parents to take the child home. Take 7 seconds. Time. If you chose B, you are absolutely correct. These are classic signs of hypoglycemia. Providing 4 ounces, which is half a cup, of orange juice delivers the immediate simple carbohydrates needed to stabilize the child based on that 15-15 rule.
Question 4. The nurse teaches a parent about rotating insulin sites. Which statement shows the parent understands? A, I will inject in the same spot to keep it consistent. B, I should massage the site for 5 minutes after. C, rotating sites prevents hard lumps from forming. Or D, I will only use the child's arms for injections. 7 seconds. Question 4. The nurse teaches a parent about rotating insulin sites. Which statement shows the parent understands? A. I will inject in the same spot to keep it consistent. B. I should massage the site for 5 minutes after. C. Rotating sites prevents hard lumps from forming. Or D. I will only use the child's arms for injections. 7 seconds. Final question. A child has a fever of 39.2 degrees Celsius. Which intervention is strictly contraindicated? A. Administering acetaminophen. B. Providing extra oral fluids. C. Administering acetylsalicylic acid. Or D. Sponging the child with tepid water. 7 seconds on the clock. All right, it is C. Administering acetylsalicylic acid or aspirin. As we hammered home earlier, aspirin is strictly contraindicated in children due to its direct link to Ray's syndrome, which causes acute brain and liver damage.
All right, how did you do? Did you fall for the aspirin trap or the PKU diet? Let's tally it up. If you got a 5 out of 5, you are RN ready for your exams. Drop your score in the comments below and make sure to save this explainer for your final review sessions. I want to leave you with this final thought. Are you just treating the symptom, or are you mastering the entire system? Knowing these metabolic and endocrine traps isn't just about passing a standardized test. It is about having the deep clinical knowledge required to save a child's life when seconds count. Keep studying, stay focused, and I will see you in the next Masterclass Explainer.